Hello, everyone. This is Rebecca Salauda from Tosa Together. I'm happy to welcome you to Tosa Talks, Building a Diverse, Thriving Community, an ongoing Facebook Live series proudly sponsored by our generous friends at Bostic. This 3-track series provides learning opportunities and fosters meaningful discussions around racial and social justice issues in an effort to build an inclusive, anti-racist community. Tosa Talks highlights input from local neighbors, community leaders, business owners, and government or organizational representatives, as well as provides sought-after information from local experts on anti-racist, equity, and inclusion issues. We are happy to welcome Dr. Madelaine Tully as our featured speaker for tonight's Tosa Talks presentation, The Personal Impact of Healthcare Inequalities. This personal stories track streams live at 7 p.m. on the second Tuesday of each month. We hope you will also join us for the Equity and Inclusion track on the third Wednesday and the Government and Organization track on the last Thursday of each month. All presentations are recorded and available on this Facebook page or on the Tosa Together YouTube channel. We welcome and encourage you to take part in the Q&A session tonight. Please add your questions to the Facebook comments section. So let's get started. It is my pleasure to introduce host Robin Luther, who will introduce tonight's featured presenter.
Hello, and welcome to tonight's presentation called The Personal Impact of Race on Healthcare Access and Outcomes. It is my pleasure to welcome Dr. Madelaine Tully. Hi, Madelaine.
Hi.
Let me start by giving the audience a little peek into your background, and then you can go from there. Dr. Tully graduated with honors from the University of Wisconsin School of Medicine back in 2000. She's worked as a family physician at the Progressive Community Health Center in Milwaukee since 2009. Dr. Tully brings more than 20 years of diverse experiences, especially in family medicine, to her work, and currently is at the Progressive's 2 clinics, including the Lisbon Avenue Progressive Community Health Center and the Hillside Family Health Center. She works daily in cooperation with a team of doctors and specialists in the medical group at Progressive Community Health Center to serve her patients. Welcome, Dr. Tully. We're so glad you can be with us tonight.
Thank you.
How are you today?
I'm good. It was a pretty typical day. I was very proud to have my diabetes support group this morning, where we have a small group of patients who work with me. We have a diabetic educator, a clinical pharmacist, and also one of our behavioral health consultants. And we talk about diabetes, about, how to best manage it, foods to eat, and then also kind of the personal impact of diabetes. And so that's one of the things I'm really happy to do. We've been meeting monthly now for over a year with this group, and the membership kind of goes in and out, but it's definitely one of the highlights of my month.
Oh, that's very neat, a team approach to that whole support group.
Yes.
Yeah. I thought it might be a good idea to have you just start off our conversation by giving us any additional background information that you'd like to share, as well as just your general thoughts on your decision to work at the Progressive Clinic, a little history and overview of your role at the clinic itself.
Great. Yeah, I grew up in Milwaukee. I actually was born at what was called Mount Sinai at the time, but Aurora Sinai. And when I was a medical student, I went and inquired about my birth records, and they said that the records were too old and they were sitting in a box somewhere in Microsoft. But yeah, born at Sinai. My parents are I'm interracial. I have an identical twin. Her name is Margaret Arney. So if I look very familiar to anyone on this feed, it's because, yes, I'm her identical twin. We look alike and we sound alike. Our hair is a little bit different right now. So when you think about it, I've really come back to Milwaukee to try to have an integrated experience, because that's the experience that my parents gave to our family. We grew up on the east side, but we went to grade school at a very small Catholic grade school and right off of Capitol Drive. And so it was very much, school in a Black neighborhood, but then living in a white neighborhood. And then I went to Rufus King, which is a magnet high school. and also integrated. But then when you got to the classes levels that I was taking, it was mostly white and more privileged students who were taking the harder classes. And then fortunately went off to Harvard. We didn't think I was going to be a doctor until my first job when I worked for the Department of Health and Human Services. And I learned all about community health centers. And so it's really a wonderful kind of act of fate that so many years later, I found my real calling at a community health center.
That's interesting. And the clinic that you work for is referred to as an FQHC, or a federally qualified health center.
Yes. Mm-hmm.
Maybe you can describe a little bit about what that designation means and tell us a little bit more about FQHCs. Like, for instance, where are they located and who can or who do they serve? Maybe why are they important, and the access of your care at people at federally qualified health center.
Yep.
Not
so I compared
familiar
to that.
To everybody. Yeah.
Yes. So there is a Wisconsin Primary Healthcare Association, which is the association of all the the federally qualified centers here in Wisconsin, and that's WPHCA. So WPHCA.org is the website for the community health center. So that will address any questions you may have. But basically, to be a federally qualified center, you have to be located in a federally designated medically underserved area. It needs to be a nonprofit, tax-exempt organization or public entity. We need to offer a sliding fee scale and provide services regardless of the ability to pay. Okay, so anyone from no insurance to private insurance, state insurance, any type of insurance, Medicare, all that. We take all insurances, but we're really focused on taking care of those with the least health insurance coverage. And we must have a board of directors. A majority of our board of directors need to be users of our services. So medical patients and dental patients. And they also need to be representative of the populations that we serve. Okay, and so that's really important. We have federal reporting requirements, so we're held to a standard of quality. So looking at things like colon cancer screenings, breast cancer screenings, well child checks, immunizations, and all that, that's monitored very carefully. And we are set, we have federal goals. We also have goals within the state as far as how much preventive care we do. We must leverage additional resources. So the federal contribution is intended to be only a portion of the health center's overall budget. So we need to be looking at grant funding and other types of funding to support our services. And we also have a compliance manual for the health center program compliance. It's a big federal document, so we have to comply to all kinds of rules, which is, I think, really good. I think people may have an impression that people who are poor or don't have insurance somehow get a poor quality of healthcare. And when you're in a FQHC, the doctors, we have to be very well credentialed. We can't have any marks against us with the medical board. We need to have full licenses, and we need to be board certified. And so that's something that if anyone who has a medical license can put out a shingle anywhere. But if they're totally private practice, then the patients have to rely upon that doctor to be honest about their credentials and what, if they're keeping up with their medical boards and things like that. And I absolutely have to meet these standards in order to practice and see patients who have Medicaid. We also have to provide comprehensive primary care. And we have to, we are actually experts with the Affordable Care Act. And so you can come to Progressive if you have any questions about the Affordable Care Act, you think you might qualify, or you think you might even qualify for Medicaid. We have financial counselors that work with anyone to see what is available for you. Because really, when we think about a safety net, I want folks to really understand that there isn't anybody in this country who can't benefit from something that our government offers, okay? And to not look at a stigma of, oh, I have to get insurance, state aid, I have to get this, I have to get that. It's a safety net so that we can help you, so that we can provide health and we can provide some equity in the community. And so I understand that there's a certain amount of stigma, but I would hope that people can see it as a resource and not as somehow something they stumble into accidentally. And I personally will provide the same care that I would at any clinic. I'm a pretty good doctor. I've got a pretty good reputation in town. I could work anywhere.
We've
And
heard that.
yeah, I choose to work at Progressive because that's the population that I love the best. And so that's really my personal reason. So I love federally qualified community health centers. We don't do a lot of advertising. One of the reasons why we don't is because we have very limited availability, because we have limited providers. They're not a lot. Every health center that you would go to, say they're looking for providers, they're looking for nurse practitioners, and they're looking for physicians. And so if we were to do a big ad campaign and we say 1,000 people want to come to the clinic, we can only accommodate a handful. And so that can be really frustrating too, to say, okay, I just heard about your resource, but now I guess I have to be in line or I can't get an appointment for 6 months. So there is definitely still access problems. And in the Milwaukee area, we have 4. We have Progressive. We have 16th Street, which has satellites in southern Milwaukee, also in Waukesha. We have Milwaukee Health Services, which services most of the north side. And then we have there's a very small clinic called the Gerald L. Ignace Indian Community Health Center, Ignace, yeah. And so those are the ones that are in Milwaukee, and Outreach Community Health Centers, which is on Capitol Drive. And so they're really great. I do also want to let people know that in order to qualify for a federally qualified community health center, you don't need any type of insurance, but many of our patients will find that they do qualify for Medicaid, which is the state health insurance. And in order to qualify, you need to be at or below 133% of the federal poverty level, okay? And so I got the numbers from one of my colleagues, and so your pre-tax income for a family of 4 monthly would be $2,903. Okay, so that sounds. I mean, if you're making a fairly good wage, $2,903 a month doesn't seem like it's so bad. But if you imagine for a family of 4 living on that, if things get pretty tight pretty quickly, and you think about, okay, so average rent is say somewhere between $800 and $1,000 a month. Well, that's
a third of your income right there.
That's your income. Yeah, that's a third of your income.
Mm-hmm.
All the gas, clothes, food, those are they say they pay the same prices as someone who's making 10 times that amount. Okay. And then you think of any family, any month you have a $200 to $300 expense that just comes out of nowhere, a busted tire, the Wi-Fi goes out, something happens, and now, you're really stuck. And so I think it's a huge benefit that a family making that much money can at least have their basic health care covered by the state. Now you make any more than that, and they cut you off. And then what are you going to do? And that's where we get people who are in this bind where they're trying to move ahead, but the cost of losing your insurance with the state insurance is really, that can be really devastating. Imagine if you have diabetes, okay, and you have to come up with thousands of dollars a year for insulin and all the testing supplies and things like that. And Medicaid pays fairly well. Medicaid helps out quite a bit when it comes to those costs, whereas an insurer for a job may not. And so a lot of people who want to make more money find that it's really tough to lose some of those benefits. And so it's just something to kind of think about. And I would love for our legislators federal and state and all that to find ways to make the Affordable Care Act work better for families, so that there's not such a drop off. Like that, it would be nice that if you make more than for Medicaid, then you can join the Affordable Care Act and still get insurance that's going to work for your family and not feel like you're taking a hit because you're trying to do a little bit better. So, yeah,
Right.
so when I think about it for myself personally, why do I love progressive and why do I want to work with the underserved is I just love people who are really present for their lives. Like they have to be very present every day, really making things work for their families. And I love that people, they're very motivated to come see me, like in order to get to the doctor. And if you imagine folks who really don't have a lot of income, they have major needs for shelter, food, transportation is a huge issue. And so, for them to take time out of their lives to come see me as their doctor, that's a huge priority. And I like to be there for them. Yeah.
Right. You kind of started touching into the next question I was going to talk about, is like a little bit about the different barriers that stand in the way of good health care. You mentioned transportation, you mentioned insurance or losing your insurance when you make more than you qualify for federally or for Medicaid, and having to go perhaps on a private insurance that has high deductibles, things like that. Are there other barriers that you see standing in the way of good healthcare? And are there barriers that you feel especially impact people of color?
I think that there's if you ask anybody, they'll have their own list. I think it's very personal as far as, because we have what we call a no-show rate. So people who can't make it to their appointment that day or just don't come in. And that's really hard to deal with for any clinic because it's an opportunity lost. We can't do anything with that time. That's time that just goes by. And we're always trying to figure out, well, why don't people come? And when you really ask people why don't they come, they have an individual reason for why they didn't come today. And so I try in my life not to conflate things. So I don't want to bring things together that shouldn't come together. Like, oh, this person didn't come to their appointment, so they must not care. If I start conflating things like that, then I'm going to be an unhappy doctor and I should find another practice. Okay. Because I'm going to think nobody cares. I know that people care, but for whatever reason it was that day, that visit wasn't happening, and it could be as simple as their phone died or they had to get a new phone for whatever reason, and then they lost their old phone. We have their old number and they didn't get the reminder. That happens. It can be as serious as they had to take somebody to the emergency room and they were stuck, or they had a work commitment or something that came up, or they have a job that won't let them leave, or they,
Right.
So I think that the farther down you go, as far as looking at the types of jobs that people have, the more of a service job you have or a warehouse job or something, they can be very rigid as far as time off and things like that. And you can, a lot of them, they have 3 strikes and you're out type policies and things like that. So for the folks who are working, that can be a huge barrier, just being able to find the time to get to the doctor. There's also plenty of barriers when it comes to people, say, who aren't working, say you're disabled, and maybe you're relying on family and friends to take you places, and maybe those family and friends just aren't available the way they used to be. So I think everybody has their own set of barriers, and we can all think about our own barriers in our own lives. Why,
Right.
Why don't we do the things that we know we should do?
Right. So as a doctor, when you're trying to help people overcome their individual barriers, and I admire how you look at them as far as individual barriers, and you're trying to help people access good medical care. Can you relate some of the experiences that you've come across of people who have like continued difficulty accessing care, are barriers typically like, I couldn't make that appointment because I don't have the transportation to get there, or my boss would not let me off after all, or if I decided to go to the doctor this week, I didn't get paid the overtime that was coming to me, individual things? Or are barriers typically more often something that's snowballing on people and having cumulative effects? And what does that mean for their healthcare access and for their healthcare outcomes?
Well, if you can, I would say that I see a lot of people getting motivated for a certain period of time. So, for example, I met a man last year who he was in his 60s and he had a heart condition called heart failure. And he had just been in the hospital. He was really motivated because he was coming out of the hospital. And we saw him consistently for about 3 or 4 months. And then unfortunately, I just got the notice this morning that he has passed away at age 65. And I noticed that after those 3 or 4 months of seeing me, he had one no-show and then another no-show and then nothing. And now he's dead. And so that's a reality. So whatever it was that the reason was, he has passed away now. And I can only look into, the crystal ball that I can imagine, but I think for him, maybe he was just tired of it. Maybe he was tired of trying to go to doctors. I personally think he was also tired of trying to follow a bunch of rules that he didn't want to follow, but that's part of it. And, at some point then he ran out of medication, and then who knows, I can't say how we also we can't go chasing after everyone. We make several attempts to have people come back, but if it's, we don't have the resources to keep chasing after somebody. So if you imagine if he had more, if he had a daughter, if he had a son, if he had a wife that was able to get him to the doctor, if
Right.
he had some kind of a case manager, somebody who could go get him and scoop him up and bring him back to me, that would be great. But my thoughts for this gentleman is that he didn't have his own social safety net. So he was lost, and now he's dead, and it's sad, and I do see that, so I see families kind of rally around crisis times, and then after a while, everybody is busy, and everybody, people, there's a lot to do for a lot of people.
Right.
And the fewer resources you have, the harder it is to do for everyone. And just looking at the poverty line too, if you look at trying to manage, just even as a single person, you qualify for Medicaid with, you're getting $1,000 a month to do everything you need to do as one single adult. That's not a whole lot.
Right. That's not a lot. Yeah.
And so, so it's constraint.
So I know that you talk about then there's always need for more doctors and more NPs and at the clinic. Can you tell us, personally and as a member of a staff, what level of efforts and actions are you able to take personally to make sure that people have access to treatments and services? Or do you have to hit a certain level and say, this is what we can do to inspire people to come in, or to clear the barriers for people to come in? That must be very frustrating.
It is, but we do, the nice thing about federally qualified community health centers is that we have financial counselors, we have a social worker that's on our staff, but she's a social worker for all of Progressive. Okay, so it's not like she's, she's got a lot on her plate any given day.
Right.
We do, for diabetes, we do have a clinical pharmacist who works very closely with our diabetic patients, and that's that's been a great boon. We've had her for about 6-8 months. And we have one nurse case manager who's mostly working with folks who've been flagged because they go to the emergency room a lot. And so we're trying to get them into their primary care. And so there is some help. Our nurses work very, very hard. They're on the phone with the patients trying to solve problems and then trying to find the ways to get in to see us. And so but it's never enough. Like, it's never enough. Like, the community that surrounds us is very high need. And there's, it's really, it can seem overwhelming. And so I work hard myself in my personal life to avoid burnout. Okay. Because it's important to me to have a long career. I don't want to just do this for a couple of years and then hop out of it. I want to do this for, so I would like to do it for a few more good years. I'm thinking, I've been doing it for 18 years now this year. So maybe 25 is nice brackets around 25 years of full-time primary care in the inner city. I think that's a nice credential to have. So I can't let myself get too bogged down with the possibilities.
Okay. I have. Go ahead.
Huh?
I didn't mean to interrupt. Go ahead.
Okay. I'm just seeing that there might be some questions coming up.
I have some other questions that I had in mind, but there's been a question that was brought up on Facebook that I think would be a good segue into right now, if you don't mind. Somebody is asking, just in general, the idea of poverty impacting health, apart from a basic access to healthcare. This person is wondering, what are your feelings about like poverty as a barrier to healthy food? Or, and this might be a whole different and its own topic of discussion, but poverty also as implications as COVID hitting communities of color disproportionately to other communities. Where does
definitely when you think about poverty, you have to really think about the grocery store, okay? And people who are really budgeting, who don't have a whole lot, are really looking for ways to feed their family consistently every day, day in, day out, okay? And a lot of people have a lot of mouths to feed and not a lot of money. And so it's not, again, we don't want to conflate the poor diet with not caring or not being interested or whatever. But when we also think about generations of people who are growing up with fewer resources, what you learn is what your family did. And so if you do your big shopping once a month where you're getting all your staples, you're just trying to go to that grocery store maybe 2 times a month, if maybe 3 times, but they're really trying to get everything when the money comes in. And so we're looking at shelf stable food, we're looking at canned food, we're looking at frozen food, we're looking for bargains, and we're looking for, we're looking for things that you can get a lot of portions out of. And then on the other side, we see a lot of people who are eating more convenience type foods because they also, some people have the cooking traditions and then some people don't. I mean, there's generations now that I see that really they're eating a lot of prepared foods. Either it's foods that are like fast foods, or it's foods that are like banquet, or prepared like frozen meals and things
dinners,
like that.
Yes.
TV dinner type things. Fresh vegetables are expensive, and even if you have the transportation and the wherewithal and the time to get to a farmer's market, you're not going to find everything you want at a farmer's market. And as I hear it every day, the fruit goes really fast. You have kids at home and you buy a bag of apples, that bag of apples is going to be gone in a day or two. And that's great. I'm like, yay, everybody loves fruit. But they're like, yeah, you got another $6 for me to go buy another bag of apples today,
Right.
you know? And so when I think about a $6 bag of apples, and when I try to translate that into my budget, like what do I have? That's probably imagine something like $60. You know, if you just go into the grocery store and add up to say, okay, someone who's at the poverty line, you know, they're trying to get by on a family of four. If they're right at the poverty line, they're trying to get by with, you know, $2,000 a month for four people. Well, if your family's, you know, maybe you're taking home $4,000 a month, maybe you're taking $5,000 a month. So you just double or then triple the prices of what you see in the grocery store and say that's what they have to pay. That's what it's coming out of their budget. And so you're not necessarily going to pay $12 for a bag of apples. You're not necessarily going to pay $6 or $8 for bread. You know, you're not, you know, you want, or, and then the organic, I'm sorry, you know, that's too much.
Right.
It's too much. And so it's not that people don't want the healthier foods, and it's not that they're not getting a message about healthy food, but they, you know, I think it's a little bit defeating. And then also it's the traditions that they've learned from their parents and their grandparents of just not really eating as, you know, as healthy as one might hope that they would eat. And then the other side is pleasure and fun. And when you look at the TV, we're always getting messages for snack foods, sodas, and things like that. And those things are cheap and plentiful. Okay. So, and then when you think about COVID has disproportionately hit people who are in service jobs, people who, and many of the folks in my neighborhood are caregivers of some kind. They also do, you know, they do frontline type jobs or housekeeping and things like that. And the community was quite, you know, devastated by COVID. So it's, you know, it's hard. Just imagine anybody, I don't care how much you're making, if you miss a paycheck or two, you're in a bind. Okay. And for people who are going from paycheck to paycheck, to have that disruption of their lives can be, you know, really stressful. So, and then our eviction rates are terrible in Milwaukee.
Right. Somebody on one of our listeners was wondering if you have seen a lot of patients with COVID, if that's been your experience in the last few months.
Luckily, we have had a special respiratory call-in line, and so people with symptoms of COVID have been streamlined, and there is COVID testing available at Progressive. So I have seen face-to-face just a few people that I knew had COVID, usually ones who are recovering and then trying to get back to their lives. The community has been a hotspot, and there are a lot of folks who have been hospitalized or lost their lives to COVID. But in my personal life, as far as seeing them, I feel like I was actually in a better shape than most average grocery store workers, because everyone coming into my clinic had some questions asked and their temperature checked. I haven't seen anybody with a cough in months. You know, we've been doing good. I've been going to work this whole time. I've had several negative COVID tests. I haven't had any symptoms. And so I feel very well protected from COVID in a selfish kind of way, because we've been doing our job as a clinic, and we've been keeping the clinic open. I did a lot of telehealth in March, April, and May, but recently people just want to come in. And so we've been seeing them, but we're keeping our distance, wearing our masks, doing their hand hygiene and all that. But yeah, COVID has devastated so much of Milwaukee. I mean, it's really sad. It's really sad.
Yeah. We had another question come in that I can combine with a couple questions that we had discussed. We were going to talk about your role as an advocate for people's health. and the idea of what other people can also do to help advocate for the issues that you see are needed. And another person has asked if there are areas of medical research that you'd like to see more focus on in the future. And so I'm wondering if you can just speak looking forward. Are there areas in healthcare that you think would help people in general, specifically help people of color have more access and better outcomes from healthcare, whether that be advocacy for certain issues or specific research into certain areas?
Okay, well, to start with advocacy, I think that one of the things that I do, especially if I've noticed that a patient has gone around a few times, because we have a referral specialist, so they need to see, say, the orthopedic doctor for their knees. So they come in, they see me again, they haven't seen the ortho. Well, why was that? Because of yada, yada, this and that. If it's gone around a couple of times, I will actually call, I will use my office time with them to call and help them schedule that visit. And it's kind of like when you hear people who, families, immigrant families, where the children have to call to explain, you know, to get something done for their parent who doesn't speak English that well. You know, it's a little bit of a professional translation. Like they're much nicer to me because I'm the doctor, and it's very rare for a doctor to call. B, I can often problem solve whatever barrier much easier than the patient can. And so I don't like doing it because I want to spend my precious few minutes with the patient doing what I want to do. But if they're not making it to their specialist because of a communication issue, I can help just bust through that. But I have other people on my team who've probably already tried, but they've all kind of run into barriers. I think that anybody can do that, and that one of the things that might be helpful is if someone's looking for an opportunity to volunteer, looking at, say you yourself have been a cancer survivor, looking at, say, ABCD after breast cancer diagnosis, or finding a group that advocates for a specific kind of problem or issue. Say you have irritable bowel, you want to look at, you know, maybe the colon cancer society or some group or some organization that has a personal tie-in for you, where you feel like you can be of help. Okay.
Mm-hmm.
And there's a lot of ways to be of help in the community. And I'd say that the best way to engage with people who aren't really necessarily like yourself is to find a commonality. Okay. So say you have rheumatoid arthritis. There's plenty of people with rheumatoid arthritis who look all kinds of different ways who could use some help, you know. So finding, say you have even a medical specialist of your own, and you can always ask them, you know, do you have other patients who have this condition? I would love to be a resource for someone if they have questions, or I would love to be an advocate. And you would be amazed at how grateful it would be, you know, people would be to find out that you're just interested. But I look at it more as find something in common, rather than trying to make something up, or, you know, something that you don't have a particular interest or passion in.
Right. Any thoughts on the research question, or is that something to think about further?
Yeah, I actually am involved in community engaged research. And so researchers are trying to, what really needs to happen from a research standpoint is to include more people of color and people of different ages, ethnicities, and all that, women into research. It's right now, it's just very difficult from a basic research standpoint, and then from a social research standpoint. So, yeah, I'm a big advocate of that. And just, there's so many people who've just never been part of the story. And just think about hypertension, you know, for most of the seminal studies on hypertension were on men. And the easiest people to find for research subjects were the people that were around them. So there are other kind of young middle-aged white men. And those are the people we know most about. So,
Right.
So yeah, I think that there's anything that's worth researching is worth researching in a diverse community. And I don't like a lot of the, I have a lot of trouble scientifically with the racial categories that we have, because I'm personally biracial. And we're all we're all a lot more alike under the skin than we like to, than people like to say. And a lot of these things that come out as racial disparities are also economic disparities, racism, things like that. So it's not necessarily a biological thing. It's more of a social cultural phenomenon, which is absolutely true. And the thing I would be remiss if I didn't talk about stress. Okay. And when I talk about money, I'm talking about stress. And I think that anyone who has ever felt financial stress, as I would assume that everybody who's listening at some point in your life, for whatever amount of time you felt some financial stress, imagine living that way in your whole life. Imagine your life of scraping by. And that is what people have to do when they qualify for Medicaid, because they don't have a whole lot. They don't have a ton. And every day, it's an issue, and it's a weight, and it makes our bodies react. We have more cortisol, which is the adrenaline type hormone. And after a while, it wears and tears on you. And so it's not like people are spending every day feeling so down and sad, but it's a constant struggle. It's a constant struggle.
I'm going to jump ahead in my questions to something I wanted to ask you in a little bit, but I think you kind of are talking about it in a different lens. But I'm wondering what you think about the effects of racism in general on people's health. As you know, in the past few weeks in Tosa, a lot of residents have experienced a sense of heightened anxiety from a perception of danger or fear. The source of that anxiety is different for different people. But I can't help but equate those feelings, which might be new to some Wauwatosa residents, to a sense of danger or fear or exclusion that are experienced by people of color on a daily basis in the form of microaggressions or even macro racial aggressions. I'm wondering if you can talk about that kind of recurring exposure to that type of stress, or feelings of exclusions, or feelings of being in danger or in a place where you're in danger. How do those express themselves in terms of people's health? And do you see that playing out for your patients that are people of color?
Well, the racism, I like to think about it more as an institutional racism. Okay, so it's not so much an individual thing, but people definitely have had experiences like that. And I can tell you that it's, again, not something that people are spending a lot of their day every day contemplating how much people are racist against. You can't live your life if you're going to be thinking everybody's against you all the time. But it's really hard to look at your community and your family and see how it is not, people have not had the same, they have not been given opportunities. They have not been able to claim opportunities. Just imagine someone who's just trying to own a house. Okay. Home ownership in the Black community is not very high. And it's because people, historically, the families have not been able to get loans for houses. And so they've been generations of renters. And it doesn't feel good to know that your family has been behind, and I think that, I don't know, I just say that for myself, I don't think that people that I know, and I've asked them, occasionally, if they think that there aren't like individual white people that they necessarily blame, to say, oh, this person's bad, or that person was bad to me, or whatever. But there's just things that happen. If you're walking in a certain area, folks, they know that they might get, they might get yelled at, or they might hear, and they might be called a name. People definitely everybody has a story here or there of being treated in a way that wasn't very respectful. But I think most people don't dwell on those stories. But when you think about the institutional aspects of racism, and you think about, just say, going to an emergency room, if you're an African American and you're going to an emergency room with a headache, there's a higher chance that you'll just be turned around. They won't necessarily give you anything or do much of any kind of a workup for you. Whereas if you look different, maybe they treat you a little bit different, that sort of thing. There's a lot of examples out there of Black people systematically not being considered to be in as much pain as white people, not getting the same amount of a medical workup, not being given the same medications. There is actually a phenomenon which I call protective racism. When you look at the death rates of middle-aged Americans in the mid-2000s, it actually went up. And that was because of the opiate epidemic. And African Americans did not experience the opiate epidemic the same way because they're just not given the medications that white people were given. So how's that for crazy and nuts? You know, the thing that my profession did the worst at, which is trying to manage pain with opiates, actually overtreated and has consequences then of so much of the opiate epidemic, which then African Americans, because they were not overtreated, maybe had some protection. It's just
some unusual irony there. Yeah,
just a little bit.
Right.
And then, you know, personally, I think I've been I've been healthy. I've been blessed in my life that I don't feel like I've had a lot of overt racism towards me, but I've never went looking for it. I have never asked anybody's permission, like, oh, do you think I would be or whatever. I was just raised to go ahead and do things, but also, you know, I have my mother is my dark-skinned parent, and my mother busted a lot of barriers in her life and her career because she simply went ahead and did what she wanted to do, as if there wasn't going to be a barrier. And that's something that I've been privileged to experience and to have as my role model.
Right.
And,
Right. So, you know, in general, there's been a pretty, well, in addition to the things that you're mentioning that are current, there's also a really unfortunate documented history of mistreatment of African Americans within the health system historically.
Yep.
Do you see a residual effect of that in histories of a current mistrust of doctors or clinics, or a lack of people going, like, volunteering for research or coming in for even just for regular checkups? How do you see it unfolding?
It's easy not to go to a doctor when you know that there's historically doctors have not necessarily had your interest at heart, or you feel like doctors have come into your community to prey on your community. Okay, so it's easy to fit that narrative, especially if you don't want to go to the doctor. There are a lot more African Americans who don't go to the doctor, you know, who should probably go to the doctor. And it fits into a lot of things. If you've got a lot of other priorities in your life and you're pretty much sure that, or you can tell pretty easily that maybe they don't care about you, or if you go and you just feel like nobody's paying attention to you, nobody's listening to you, they don't think your problems are really that, you know, big of a deal, then why participate? You know, why enter into a relationship with someone who might not want to have a relationship with you? But I would say that is broken down immediately in a personal conversation, and that I would hope that anyone who feels like they haven't been treated with respect by people in the medical community continue to look, you know, and continue to try to find a doctor that they can relate to, that's somebody that they feel will treat them well. And as I've said many times to many people, there are too many doctors in Milwaukee to be unhappy with the one that you have. Okay, and so if you don't feel like you're being heard, you know, find somebody else, talk to another person. But that also assumes that you can, you know, that you're not as limited as some are to the doctors that are available to them for whatever reason.
So you're at your clinic, Dr. Tully, I mean, basically anyone can come to your clinic.
Yep.
They would have access to your clinic whether they have insurance or not, and be billed in a way that respects their ability to pay.
Yep.
What do you advise for people how do you form those good relationships with your doctor and with your healthcare providers? What are the key elements of that?
Just come in with an open mind and be willing to talk, and just be an advocate for yourself. I think people we're all familiar with celebrity culture, and just think of the doctor as your consultant. Okay, you know how all the celebrities they have their consultant, they have their people. You know, the doctor is going to be one of your people. Okay, the name of the game is that you get what you want, and you need the people around you who are going to get you there. Okay, and so to really kind of feel in yourself that this doctor is here to help you. This doctor is here to be your advocate, but it's really essentially a consulting relationship. I have 15 to 30 minutes of your time once every couple of months. Okay, that's not a whole lot of time. And so I'm not going to be able to mold your life. You're the one that molds your life, but I can give you some really good advice about how to do that. Okay, and I can hopefully work with you and be curious and interested enough in you so that you'll want to come back because you'll want to keep me involved in your story. Okay, and if you're not getting a vibe like that from your doctor, if you're not getting a feeling that your doctor is happy to have you there, or wants to be there, wants to be part of your team, then I would say move on, find somebody else.
Right, right. Well, this
And
hour,
yeah, no, I'm sorry. That's one thing that is difficult for folks who feel like they're not necessarily going to be given that kind of respect, you know? So it's something to kind of work with people too, to say like, you can talk, this is your time. You know, you have to give yourself that. So,
right.
So is there more questions coming at us? Oh, I want to say progressivechc.org is our website.
Progressive, say that one more time.
Progressivechc, one word, .org.
Progressivechc.org. Okay.
Yeah.
We do have one person is just asking with your patient population at Progressive, do you find there's a stigma attached to seeking mental or emotional health care?
Absolutely. Absolutely. But who doesn't have stigma? Tell me a family in the US that doesn't have somebody who has a stigma about mental health.
Right.
You know, but there is a lot. We do have what we call integrated behavioral health. So during a regular medical visit, if we identify that you're having a mental health issue and you would like to have some counseling, and we do that for insomnia, smoking, anxiety, depression, the whole gamut, they'll come right in the room and talk to you. So it doesn't feel like you have to go to a whole nother clinic, or you even have to make a whole separate appointment to really get that started. I'm very, very proud of that.
Mm-hmm. Mm-hmm. I'm looking at our time and realizing that this hour just flew by underneath us here. Maybe I'm thinking it's just as a last closing thought that you could talk about just the idea of someone who has disparities or is more vulnerable to the barriers of healthcare, just a way to frame that idea of relating to individuals who experience disparities or are more vulnerable to barriers in society and healthcare in general. Just a closing thought on framing that in terms of healthcare and personal interrelationships.
Well, I think that really showing respect to the patients at all levels is so important, because people are expecting not to be heard. They're expecting not to get their needs met. They're kind of expecting sometimes to be marginalized, and because many of them have been many times in their lives. And so I feel it's our burden to be extra respectful and to take our time to get to know to get to know the patients and to give them all of the things that they need. And sometimes they do need a little bit more advocacy and all that, but to really treat everyone as an individual. And I'm personally just happy to meet everybody. You know, I love meeting new people. I love trying to solve folks' problems with them. So
Excellent. Any other closing thoughts you want to throw out there before we sign off for the evening?
I would love for people to learn more about community health centers, and I would love people to look into their family and friends and really clue people into the fact that we exist. Okay, and that you probably do know someone who is feeling some sort of stress, who may have lost insurance or feel like they're underinsured or feel like their insurance is just not adequate. And if they're not getting care because they don't think that they can afford it, please look into a federally qualified community health center, because that's what we're there for. We're everyone's safety net.
And the clinic that you're mainly at is the Progressive Clinic on Lisbon. That's
Lisbon.
about 32nd and Lisbon.
35th in Lisbon. Yeah,
35th in Lisbon.
Yeah.
It is a beautiful facility.
Yeah.
I have somebody asking if you can say the website again, so we can post it out.
Okay, I'm gonna see, can you, I don't know, can you read that?
Let's see. www.progressive, bring it a little closer. progressivechc.org. We got it.
Okay,
So we'll include that as part of the comments in this stream, so people will always have that.
good,
Well,
good. And
Yeah. Thank you so much, Madelaine. Thank you, Dr. Tully. It was really, really nice to talk with you. I think you gave us a great opening into our month of October. We're going to be continuing a discussion of healthcare through an equity lens. You really brought it down to a personal, at the clinic level for us, and we appreciate that. Thanks for sharing your thoughts and your experiences.